Be here, and I will discuss, first of all, pharmacological and conservative treatment of spine fractures with osteoporosis. And of course, we have to look at several aspects before we can discuss exactly what to do. The clinical presentation, the consequences, we have to review the treatment options and the risk and prevention of new fractures. And I will cover some of these aspects. Why is it difficult with vertebral fractures? Because they're difficult to study. Many other fractures are very easy to target and to make clinical randomized trials on. Because the definition of these fractures is controversial. Many of them do not come to clinical attention. And we also have the slow versus the acute onset of these fractures. And the event that causes the fracture, compared to most other fractures, is often unknown. And we also have a poor understanding of the relationship between spinal loading and vertebral fragility. So they can look in many different ways, as is shown here. They can be single or they can be multiple. And they're also located in various locations in the spine, and this is from a thesis in Gothenburg, of acute onset fractures, where you can see that the majority are in the thoracolumbar junction. So what are the consequences of vertebral fractures? Well, some of them were already mentioned. The spinal deformity, the body deformity should not be forgotten, height reduction, and the functional impairment. But we also have an increased risk of new vertebral fractures, but it's also associated with the risk of other fragility fractures. And of course, for the patient, it's pain, reduced quality of life, and mortality. And this is quite evident in this patient, which I'm sure that most of you have seen at one time or other. But her main problem is actually both the deformity but her pain, which makes her life very difficult. And of course, we should have intervened long before this happened, if we have good options. So again, these are the consequences. So what is conservative treatment? First of all, we have to look at the pain, and we have to define whether it's acute or chronic, because this is mostly what is bringing the patient to the doctor. And for this talk, I've decided that 3 months is acute, more or less, and more than 3 months is chronic. And this is what's known from the literature, that in the elderly over 75 years, 60% report pain in the spine, and 40% of nursing home residents. Most of that pain is inadequately treated. These are our treatment options for pain. It's regular analgesics, or those who are second line, which contain NSAIDs on non-opiates. So let's look at opiates instead. When you look at this overall, and you will see that after this review, there's very few good studies in the elderly about pain management with vertebral fractures. And this is true also for opioids. However, there are some formulas that have been tested and seem to be effective. However, in the elderly, you need to have individual dosing and consider the decreased hepatic and renal function, so there needs to be a slow titration. And this is one of the studies that have been performed with transdermal fentanyl. It's one of a few studies with opioids in the elderly. And as you see, it's a 4-week study, so it's short-term and acute pain, and very few patients, and not all completed the study, but nevertheless, there was a decrease in pain at rest and movement, and also an improvement in quality of life. So there seemed to be a place for opioids. Sometimes I see that these are not often used, however, in the elderly because of fear of side effects. This is another study where they used intrathecal morphine infusion instead. This was for refractory pain, that's long chronic pain instead, which is quite an extensive procedure, but the study was for 1 year, and there was a significant pain relief, and no other analgesics required. However, this is way on the side, I would say, for most patients. Nerve root injections. This is a study that was done a few years back, and with the regular nerve root injection with local anesthesia and Depo-Medrol, the follow-up was at 1 year, and you can see there is a decrease in the pain score over time. So it's a possible avenue, however, very rarely used in my experience in a clinical situation. People have tried other things. This was electricity, or a coupled electric field for pain relief in patients with vertebral fractures and chronic pain. Didn't make much difference if they used this. For the acute pain, we have also seen studies with intravenous bisphosphonates, where the primary goal was actually to reduce pain, not to treat osteoporosis. And that was also done within the first week after vertebral fracture. And as seen here, the VAS decreased in both groups, but it was more so in the treated group compared to the non-treated group, or treated with other analgesics actually. So it's not a placebo trial, of course. And this was sustained until 30 days. Oral alendronate has been used also, but more for chronic vertebral pain. And it's shown that oral bisphosphonates, who are also used, of course, to treat the osteoporosis, the underlying disease, reduce the number of bed days and the number of days with limited activity. But there was no real difference in the number of days with pain. So actually cannot be used as considered a pain medication. Teriparatide, which is parathyroid hormone, has been used in a large randomized controlled study to evaluate the effect of vertebral fractures and risk of new fractures. However, in that study, it was also shown that there was a pain reduction with parathyroid hormone, as you can see on the figure. And this was sustained. And of course, this is a randomized controlled trial with placebo. Calcitonin was used previously to treat osteoporosis. It's no longer on the list in Sweden, at least. But in this study, which is a systematic review of those trials that have been performed, you can see that calcitonin actually decrease vertebral pain from vertebral fractures at 1 week, and it's sustained at 4 weeks. And that was previously one of the possibilities used, but it's much less used today, mostly because of side effects. So conservative treatment without pharmacological interventions, which is what we normally use: bed rest, aided mobility, braces, and physiotherapy. As far as I could see, there is very little evidence for efficacy of any of these modalities. However, there's one study on spinal orthosis, which is randomized over 6 months, and showing a partially beneficial result for those who had this particular brace. No replication studies have, however, been performed. So that's really all we know about conservative treatment for these fractures. So what's the outcome of conservative treatment? Well, this is again the study from Gothenburg, where patients were followed for 1 year. And if you just look at the 1-year result, you can see that most of the patients are not back to any normal state even after a year. And it's worse depending on where the fracture is located and what type of fracture. Where crush fractures have a worse outcome. And this is our normal standard care, conservative management, which is then not very successful. And of course, you might also know that those with vertebral fractures have a higher mortality rate, particularly in the long term. So these are what we today are using in conservative management of these fractures. The outcome of it: it's still insufficient pain relief, not a full effect because of side effects in the elderly. The functioning is still restricted, and there are additional negative effects from these treatments. There's also long-term management, which includes the risk of new fractures and prevention of new fractures. And as you can see, if you have a spine fracture, you have a risk of virtually all other fractures, but of course it's highest for new vertebral fractures. On the good side, though, is that we actually do have effective treatments for osteoporosis that increases bone strength, which is most important for vertebral fractures compared to peripheral fracture, where you always virtually have a fall.